Hi, I'm Rowan, and I'm here today to do a demonstration of a manual removal of a placenta. And then I'm also going to be giving my reflection on experiences, insights, um, and theoretical literature on the practice of manually removing a placenta. So, first, I'll do my demonstration. And the case in which we would be manually removing a placenta is if it hasn't come within like 30 to 60 minutes maximum, especially if there is a hemorrhage that's trying to be controlled. But we'll kind of get to why that might not actually be the best logic clinically, based on the evidence after I do the demonstration. But at this point, we would have already given probably 20 units of Pitocin, so 2 separate doses of 10 units, and maybe some other uterotonics, anti-hemorrhagic drugs at this point, and the placenta has just not separated. It's not showing signs of separation, and it's not coming spontaneously. There's a need to get it out. So, one of the biggest risks to this intervention is infection. So, ideally, we need to have sterile gloves on, but not just the normal kind that you use for like the delivery or an exam. The ones that go up above your elbow, like almost to your shoulder. They go up here. So we would have steriles on. Ideally, we would have had a moment to like scrub our arms with iodine, scrub in. And we would gain the client's consent, explain why we need to get their placenta out, and then go ahead with the procedure. I'm going to be demonstrating on this pelvis. Here's the front of the pelvis. Here's the entryway, the vagina, and then I'm using this orange inside here to demonstrate represent the placenta with the orange, and this is the uterus, this fabric. So, I've gained consent, I've got my sterile glove on, and I would go ahead and have the patient on their back, with a Chuck's pad underneath, of course, if possible, and I would go ahead and stick my flat hand into the vagina this way. I should turn it like this. Like so. Okay? And I would feel and I would be applying fundal pressure, like to the top of the uterus. Not super hard, but yeah. And I would be going into the vagina, into the cervix, and then up into the uterus. And what you're looking for is you're going along the wall of the uterus to feel the placenta, and then you want to just use your flat hand and your fingers like this to kind of walk your fingers underneath the placenta and start manually separating it from the wall of the uterus, until it all sloughs off and it's free, and then you'd want to go ahead and pull it out. And there's likely to be like a lot of trailing membranes, so you could go ahead and twirl the placenta with the membranes to hopefully mitigate leaving membranes behind. And definitely you'd be keeping on with the fundal pressure up here as much as possible. Maybe you're even doing bimanual compression after this, or aortic compression if the bleeding is really bad and continuous. But the thing that I've learned is really important with this is to not force the placenta if it's not peeling off the wall of the uterus relatively easily, because that could mean that there's an abnormal insertion, attachment of the placenta to the uterine wall. And if you force it, you could either cause way worse bleeding, life-threatening bleeding, or damage the uterus, or likely leave like pieces behind. So that kind of brings me into my reflection on manual removal. Here's my outline. I'm reading from the framework that was given, the 4 lenses of reflection. So the autobiographical lens, I have no personal experience with this intervention yet. I have never even seen one done by a preceptor. And there's few things left on my list that I've seen so far, so knock on wood. Hopefully it's not going to be needed soon. But funny enough, the student that came right before me in my placement, they said that manual removal was her thing because they had 4 manual removals in that 1 year. That was more than they'd ever had before. My thing has been nuchal hand, which is not that bad, and I'm happy for that to be my thing. So I've heard a lot of those stories, though, from my preceptors, including one that was just shared with me by my preceptor on a long drive to a prenatal home visit this week about her worst postpartum hemorrhage. And it was a manual removal that she did with like a bicoordinate uterus, and she had described that there was like what she described as like a tight corner in the uterus that she couldn't quite get the placenta to come, and my theory is that it was like some type of an invasive insertion, and she just couldn't quite get it to completely give, and a piece of it ended up just staying retained. They transported, and she actually had her in one of those shock garments, which was interesting to me. I've read about those in like the UNICEF organization because it is really helpful in mitigating mortality from postpartum hemorrhage in low resource settings where it takes a long time to get to a higher level of care, and that was the case for this birth too. So I think it's really cool that my preceptor was smart enough and equipped to use a tool like that. And yeah, so I've heard a lot of in detail stories and read charts from manual removal cases that came before my time, but I'm yet to have personal experience with it. The student's eyes. I definitely am feeling a level of fear surrounding this intervention kind of come up in my body when I think about it and talk about it. I think that there's multiple reasons for that. I think that part of it is the lack of experience. And I think that part of it is lack of experience compounded with like horror stories. It's also an extremely invasive procedure, and I don't do well with that at all. The more invasive something is, the more like problematic it can be for me to perform. So, that's just my view of it at this point. So, yeah, at this point, I don't feel very confident in my ability to interpret what I'm feeling inside either, because I've been doing just internal cervical checks for a long time already, and still to this day I get like pretty confused and turned around sometimes. So if I was way up in there feeling around inside of a uterus, I am concerned that I wouldn't be making the correct assessments of what is the placenta, how to peel it off, etc. It just seems like a very intense intervention. So yeah, I have a long way to go with this. My colleagues' experiences, like I said, heard lots of stories. It's definitely included in the CPM's scope of practice here, and I've heard of it being done by lots of different midwives, not just my preceptors. I haven't heard as many hospital stories about manual removals, which is interesting now that I'm thinking about it, because I work pretty closely with the hospital, and I just haven't heard any yet. But a lot of the stories that I've heard here are cases in which the birth is taking place somewhere very, very rural, and a midwife is trying to get a hemorrhage under control, and the placenta is retained. And I think that's why I hear a lot of horror stories, because it's typically like a long transport, not a very smooth transport, lack of access to EMS, stuff like that. So, yeah. The theoretical literature. So, there are a lot of risks that are objectively recorded with MROP, such as a severe postpartum hemorrhage. So, if you're trying to control the postpartum hemorrhage, it could potentially get way worse. It's not uncommon for there to be retained placenta with a manual removal as well, which can also continue bleeding and or cause postpartum infection. But I would think and hope and pray that you would be transporting to a hospital in the line of events there and getting ultrasound and a D&C for something that was retained. But I've heard of that not happening when a manual removal is performed too. So yeah, severe infection, endometritis, where the lining of the uterus gets infected, can be life-threatening to the birther for sure, postpartum. And manual removal does increase the risk of hysterectomy and injury to the uterus or the surrounding organs. Very scary. It's quite a risky intervention to perform. And bottom line is, it may or may not stop a postpartum hemorrhage. I still feel a little bit unclear with the data that I've been reading and information I've been gathering and learning, like when it's the best judgment call to go ahead and do the manual removal. Whether it's gotta be, I'm assuming it's gonna have to do with blood loss, at which point it's appropriate to go ahead and take the risk of doing this intervention. I'm still a little bit unclear about that, honestly, and I would love to hear some further insight. But also, bottom line, what I'm learning is that standard of care is for it to be done in a high-level care facility with access to an operating room, access to blood transfusion, and an ultrasound machine. That, in the stories that I've heard, is really important. So that while it's happening, they can look on ultrasound to see what other elements are compounding the situation, see if there's retained pieces, able to do a safe D&C right then and there instead of risking someone having to have a manual removal and then have a D&C after the fact. And yeah, the ultrasound is just important, it seems like, for this intervention. So what I've deduced is that, if possible, it's really the best practice to wait to just transport and then have the providers at the hospital do it instead of the midwives doing it and then transporting once the hemorrhage is getting worse. So yeah, but that's just what I'm understanding so far based on the literature. And yeah, thank you so much for listening.